Hi, I'm Dr. Vinood Methil. I'm a consultant diabetologist, clinical director at Sweet Clinics Vashi, and a consultant diabetologist at Reliance Hospital, Navi Mumbai. So today I'm going to take a case study of a newly diagnosed type 2 diabetic patient who comes with a high baseline HbA1c level. Mr. AB, he is a 45 years old, newly diagnosed type 2 diabetic patient who had come to the clinic for the first time a couple of years back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin and also was advised for lifestyle and diet modification. Then he came back again after 2 months as a part of his routine checkup, and these were his lab reports. So in the lab, his blood sugars were still uncontrolled. He had an HbA1c of around 8.5%. His eGFR was around 80 ml per minute. LDL was 80 milligram per deciliter, HDL 38 milligram per deciliter, and a triglyceride of 200 milligram per deciliter. The medication which he was taking for the last 2 months was basically he was on metformin 1 gram twice daily. He was on telmisartan 40 milligram once daily for his blood pressure, metoprolol 100 milligram once daily, atorvastatin 40 milligram once daily, and aspirin 75 milligram once daily. On physical examination, his body weight was high. He had a BMI of around 31 kilogram per meter square. His BP was well controlled. It was around 120 by 70 millimeters of mercury and a heart rate of 78 beats per minute. Now, for this patient, evidence clearly indicates that an early intervention and achievement of glycemic control reduces the long-term risk of both micro as well as macrovascular complications in patients with type 2 diabetes. So the UKPD study, which was a very landmark study for patients with type 2 diabetes, which clearly emphasized for good glycemic control in patients with type 2 diabetes and also demonstrated the CV benefit, the micro and macrovascular benefit for these patients with an intensive control. And then there was the follow-up legacy study of the UKPDS trial, which again clearly showed that an early intensive therapy because demonstrated the legacy benefit of the early intensive therapy because the difference in the CV event rate 10 years post-trial was apparent, even though no difference in the HbA1c levels was seen between intensive and the conventional therapy. The legacy study actually suggested that the failure to achieve an HbA1c less than 7% within the first year after diabetes diagnosis, it is sufficient to establish an irremediable long-term future risk of both micro as well as macrovascular complications. In addition, failure to achieve the HbA1c target of less than 7% within the first year after diabetes diagnosis may lead to an irreversible increased risk of mortality. These findings were also supported by previous cohort studies that showed that the failure to intensify diabetes treatment in patients with an elevated HbA1c values is associated with an increased risk of retinopathy as well as cardiovascular events. So when metformin is not suitable or when metformin is not complete, then an empagliflozin or a linagliptin is being considered as an alternative first-line treatment. The initial combination therapy may also be considered to achieve the target A1C target more quickly, particularly in patients with a high baseline HbA1c levels. Now, early combination therapy, especially in patients with type 2 diabetes, makes clinical sense for several reasons. So we had the landmark Verify study, which again was done in newly diagnosed type 2 diabetic patients with where the A1C levels was quite not that too high. What the Verify study demonstrated was that the strategy of an early combination treatment approach with the DIP4 inhibitor plus metformin combination in patients with newly diagnosed type 2 diabetic patients significantly and consistently improves the long-term glycemic durability compared with metformin monotherapy alone. And then we have a good meta-analysis which clearly demonstrated that an early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c less than 7 compared to metformin monotherapy alone. So for patients with an HbA1c more than 1.5% above their goal at diagnosis, the ADA and the ASD guidelines they recommend first-line therapy treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients who have got an established severe cardiovascular disease or a heart failure or a CKD, chronic kidney disease. So EMPA and LINA combination is quite complementary. Empagliflozin being an SGLT2 inhibitor acts on the kidneys, causes glycosuria, and also has got additional benefits of weight reduction, good benefit, good effect on the BP. Gives a BP reduction of about 2 to 4 millimeters of mercury, and also has got a good beneficial effects on the lipids. And then linagliptin, a D4 inhibitor, it acts on the incretin axis. It stimulates the beta cells to secrete insulin in a glucose-dependent manner. So these two in combination, they have got a complementary mechanism of action, and also have got pleiotropic benefits, which may be suitable option across a range of diabetic patients, including those with an established atherosclerotic cardiovascular disease, or those with a high risk or established heart failure or CKD due to the tolerability of the combination, in addition to the potential benefits of empagliflozin on the cardiovascular and renal outcomes, and no increased risk of heart failure with either agent. According to a study, early achievement of HbA1c goal of less than 7 with EMPA and LINA could reach the target of HbA1c at 12 weeks compared to monotherapies. Now, HbA1c decrements by EMPA plus LINA combination 25/5 has demonstrated a very good efficacy, about 1.81% reduction HbA1c reduction at HbA1c baseline of more than 8.5 at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained at 52 weeks in metformin treated groups, and a higher percentage of patients achieving a HbA1c target of less than 7 were reported for combination. The combination offers a very suitable component in strategy to achieve the target HbA1c without any increased risk of hypoglycemia or any increased risk of weight gain, with an improvement in the overall lipid profile. Now, as we know, SGLT2 inhibitors can cause an increased risk of genital infection, but when it is combined with a D4 inhibitor, studies have shown that there is actually a reduction in the incidence of genital infection can be seen when an SGLT2 inhibitor is combined with a D4 inhibitor. Perhaps this could be because of a better glucose control offered by the combination, but then there could be other possible mechanisms which still remains to be investigated. So in summary, EMPA and LINA combination provides a very robust HbA1c reduction and 2 to 4 times higher odds of patient reaching their glycemic goal HbA1c target compared to individual agents with a low hypoglycemic risk. So coming back to our patient, Mr. AB, who was initially on metformin monotherapy, but whose glycemic target was not achieved. So this patient was then put up with the combination of LINA plus empagliflozin in addition to metformin. And then this patient came back for follow-up after 3 months, and then at the end follow-up, his HbA1c had come down from 8.5 to 6.9%. There was a good weight reduction of around 4 kilos of body weight, and his lipids were also well maintained. And this patient was able to maintain his A1C target with the weight maintenance, and even after 2 years of follow-up, his A1C was around 7, was able to maintain his A1C target, and also had a good lipid profile and a weight profile. So the combination therapy of EMPA plus linagliflozin in addition to metformin was found to be very beneficial for this patient, was found to be durable, and also there is the CV benefits which is provided by this combination, which can have a long-term good benefit, good impact for the patient. Thank you so much.